Dear colleague, good morning, and thank you very much for your kind invitation. It's a real pleasure and an honor to be part of the fascinating context of your National Congress. So, this is the outline of my talk today. I will provide you the background of the neuroscientific and oncological context in which we are involved today. I will provide you also an overview of the most updated tools regarding the structural and functional study of the human brain, not only for improving our knowledge regarding the system, but also for improving the accuracy of our preoperative planning. And then we will review the most recent evidences regarding the structural and functional anatomy of the most critical um, networks of the human brain that can be monitored during brain surgery. So with this paper in 1963, Norman Geschwin opened the era of the modern neuroscience. In fact, he demonstrated for the first time that brain processing is subserved by different integrated parallel and sometimes hemispherical networks. And in fact, we entered now in the so-called the cornetome era, and the structural connectivity of the human brain is at the center stage of both the neuroscientific but also the neurosurgical research. And in fact, no one better than neurosurgeon knows that injury or damaging the critical structural pathways of the human brain can produce permanent deficit more frequently in respect to the cortical territories, considering the low or no chance of plastic reorganization at this level. On the other hand, we know very well that each surgery, each resection, especially in glioma surgery within the brain, have effects on the cognitive outcome of our patient. This is, for instance, the first and extensive neurocognitive assessment of patients underwent to radical resection of high-grade glioma, demonstrating that there is of course a reduction in their cognitive performance at 7 days, but a totally recover at 1 month if even in aggressive surgery there is a preservation of the structural and functional assessment. On the other hand, we know very well from the neuro-oncological field that the extent of resection is a crucial step for providing to our patient the best overall survival in both low-grade but also high-grade glioma. And we are still going on this concept. In fact, more and more data are demonstrating now that the residual hyperintensity and also plays a role in predicting the overall survival of our patients. And more and more data the evidences of this paper we recently published in Journal of Neuro-Oncology, comparing two series of sleep and awake surgery, demonstrated that the resection of higher portion of flare hyperintensity produce a beneficial effect on the overall survival of our patients with no differences in the end in the neurocognitive outcome. So from one hand, we have to be aggressive. From the other hand, we have to preserve these intricate maze of structure and functions of which the human brain is composed. And we have many tools now to explore at least this system much more than 10 or also 20 years ago. First of all, tractography. Tractography changed the mind of the neuroscientists, but also of neurosurgeon, because it renewed the interest for the structural connection of the human brain, and is able now to produce fascinating and outstanding reconstruction also of critical crossing and kissing area. But don't forget, first of all, that DTI is not tractography, and especially that tractography is not a real reconstruction of the structural connectivity of the brain, but this is a mathematical spatial representation um, of the direction of the fibers as emerged by the elaboration of diffusion weighted imaging. And in fact, you have a lot of different processing algorithms to produce this kind of data. Each one have pros and cons, and with different level also of specificity and sensitivity. And this is the reason why the results of stratigraphy are most of the time contrasting and are continuous also evolving. I just selected for you for instance, the pyramidal tract story. So this is a paper just of 10 years ago, 9 years ago, and at that time it was the best reconstruction of pyramidal tract with provided by tractography that, as we neurosurgeon knows very well, is not probably reliable. In the same period, it was published a paper integrating the information of stratigraphy with cytoarchitectonic maps, but the result was similar. Then it was an update of this atlas in 2016, but you still can see that the reconstruction is not properly what we would imagine regarding this tract. And now, finally, thanks to the big work of the group of Imagerie Neurofonctionnelle of the University of Bordeaux, we have a full and reliable reconstruction of the pyramidal tract. But if you really look at the threshold of probability of this reconstruction, you will notice that we have a full reconstruction of the tract just with lower level of probability. And this is the reason why, in fact, tractography is not properly the truth and is not probably, it is not yet a tool totally reliable, especially for resection, for brain resection in the neurosurgical field, because its reliability is still to have more and more improved. Maxime Descoteaux and Meyeran, I'm very proud of this paper from Maxime, that is a friend of mine, published in Nature Communication, that in fact demonstrated that this is not yet a totally reliable tool. What they did was to select a pre-filtered tractogram and to provide these to different experts of neuroanatomy in different neuroscientific labs of the world. And what they obtained was very interesting, because not only the group detected the same bundles or the same volume. So it was a big discrepancy in the kind of the bundle detection and in the feature of the bundle detected. But they also were able to detect bundles that were not included in the tractogram. So be careful. Use stratigraphy in the right way, that can be very didactic, that can improve your knowledge about the anatomy, and that can support you to add a tag in your puzzle of exploring and creating your surgical imagery of your single case. We have also new techniques for tracking, because also the way to track, so to generate the different bundle in the human brain is not so well defined. We also provided, and we are supporting the neuroinformatic labs in developing this tool that is much more user-friendly, especially for neurosurgeons, and that allow for the first time an exploration streamline by streamline, and the refining streamline by streamline of the different tracts of the human brain, that is very useful not only for didactics, not only for improving your knowledge, but also for arranging your case in a critical way. And don't forget microdissection. Microdissection is in fact now, together with other anatomical techniques, the most reliable technique for assessing the ground truth that neuroscientists are using to refine their tools and their techniques. And microdissection is also very useful to improve our own knowledge, especially about the anatomical relationship of the different structures in the human brain for surgical purpose, and to improve our surgical technique. And you have now a real chance to have this data digitalized, and to have a microdissection and ex vivo anatomical dissection data directly within a neuroradiological space, and especially you have the real chance to extract quantitative information from the ex vivo dissection and to put in a neuroradiological space, producing also interesting and interactive model for improving more and more your knowledge and for scientific purpose. What about the functional side of our tools? So we have a new and very interesting tool that is the resting state. Resting state was discovered by Bisbal in a very smart paper in 1997, in which in exploring the signal in the rest sequence of the patient submitted to classical task-based fMRI, he noticed that there were statistical significant overlap between the resting state functional connectivity and task-based activation map. In other words, he was able to extract from the rest sequence the same functional activation that they evoked with the task. And in fact, a few years after, they were able to characterize different networks just measuring the contemporary oscillation of both signal in different cortical areas of the human brain. And this is in fact the main advantage of a resting state, because from one hand, you reduce your acquisition time, because with 11 or 12 minutes, you can provide a whole acquisition and a good resting state acquisition. You don't care about the patient cooperation, or at least not like in the long and time and task based resting state acquisition. You don't care about dedicated task, because the patient just have to be at rest, and especially you obtain a whole brain network functional analysis, so you can explore the real organization of the network at whole brain level. Um, we recently published an automatic pipeline that is available online in Journal of Neurosurgery that will allow you to use your resting state sequence and to obtain automatically different networks. Testing this pipeline thanks to the opportunity of 6 patients submitted to awake surgery, and comparing the location of motor, language, speech, articulatory, and visual networks with the different with the topography, with the distribution of the networks at resting state, obtaining good results with a percentage of overlapping between 80 and 100%. But of course, it's still not enough for a blind trust. This is very useful once again to put a tag more of your puzzle in studying your patient and in approaching your patient, in arranging your preparative planning, but is not enough for a blind trust. And in fact, all these tools, and especially your culture in the structural and functional knowledge of the human brain, are extremely useful to create in the end a surgical cognition of the functional and structural organization of your own patient, case by case. And there is no doubt that in the end, the most reliable tool to verify and to test your approach, and also to be sure that your surgical planning was correct, is direct electrical stimulation, that changed the world of brain resection in glioma surgery, but also in other fields. First of all, because it pushed the resection beyond the anatomical landmarks up to the functional landmarks of the resection. Then, because it improved our neurological and neurocognitive outcomes, but also the overall survival of our patients. And on the other hand, because it provided us a unique opportunity to study the structural and functional organization of the human brain, especially at subcortical level, as we did publishing the first atlas of human white matter organization, and also now an integration between the cortical and subcortical functional distribution in the human brain based on direct electrical stimulation and 4 different brain networks. And so let's see the organization, the most recent evidence regarding the organization of some of these networks. The language network, for instance, that you know because the scheme coming from the seminal paper from Eacock and Purple is very famous, is organized in a dorsal and ventral pathways. The dorsal pathways encircling the insula subserve the mapping of sensory and phonological representation into articulatory motor representation. So it's crucial for speech articulation and the phonological organization of the language. On the other hand, the ventral pathway passing through the external capsule are crucial for maps the sensory information into conceptual, verbal and non-verbal representation. So to give a semantic context to the sensory information. And we know now very well, thanks also to direct electrical stimulation, that the systems is more complex than expected, that is observed by different subnetworks, and these subnetworks are strongly distributed between the frontal, parietal, temporal, and occipital lobe. And each one of these is connected by different layers of structures of human white matter. Let's see what's about the speech planning that you can test during surgery with a simple counting task, evoking dysorthria or speech arrest, anarthria, in other words, at stimulation. If you look at the verbal apraxia response in our atlas, you will notice that these are distributed in the lateral white matter connecting the ventral portion of the frontal lobe with the inferior parietal lobe, or in other words, the angular gyrus and supramarginal gyrus. And in fact, the mainstream of this network is the third component, so the most ventral component of the superior longitudinal fascicle connecting the ventral premotor cortex, in fact, with the inferior parietal lobe. We have also some neurophysiological proof of the direct connection, of the existence of the direct connection between the ventral premotor cortex and the inferior parietal lobe, thanks to two very elegant papers by Matsumoto that with cortical evoked potential demonstrated this direct connection. And this is an example of a pure speech arrest.
1, 2, 3, 2,
where you see 4, 5. That the patient is not able to produce the language, but is able to move the tongue. So this is not a motor response effect, but a speech articulatory block. And in fact, we characterized also this network by the punch functional point of view, thanks to resistate fMRI. This is one of the other possible application of very interesting application of resistate fMRI, the seed analysis. So what we did was to use the region in which we evocate the speech arrest in 7 right-handers patients. Regardless the side, what we obtained by the seed analysis were maps of functional activation bi-hemispherical between the frontal and the parietal cortices in all the patients. It allowed us to create a small atlas that is available online, in which you can explore the main hubs of this bi-hemispherical speech articulatory network that involve, in fact, the ventral part of the posterior frontal lobe, the inferior parietal lobe, and the insula. And as the chartography demonstrated, the main stream of this connection is observed, in fact, by the fibers of the third component of the superior longitudinal fascicle. The second component of the dorsal pathway is the phonological network. You can test it with a sample object naming or with a reading task, and the most frequent response that you can collect is a phonological paraphasia. And if you look at this at the function distribution of this response, you will see that these are in the dorsal pathway, but encircling the insular, the perisylvian region. And in fact, this is the course of the arcuate fascicle, that is the only connection between the frontal lobe and the temporal lobe, that was recently renewed with tractography by Fernandez Miranda group and by macro dissection by our group, demonstrating direct connection between the ventral premotor cortex, the pars subaricularis, and the posterior third of the middle frontal gyrus of the frontal lobe with the superior, middle, and inferior temporal gyrus. You see here an example of phonological paraphasia at the stimulation of the stem, so the most compact portion of the arcuate fascicle in the peritrigonal region during a superior parietal lobular precuneus resection. What's about the semantic network? You can test it with an object naming evoking semantic paraphasia or anomia. And if you look at the functional distribution of this response, you will notice that the course is totally different. These responses are in fact running in the deep white matter of the temporal lobe and in the anterior third of the external capsule until the dorsolateral prefrontal cortex. So the mainstream of the semantic network was demonstrated to be the inferior frontooccipital fascicle, the longest white matter bundle in the human brain, connecting the parietal lobe, the occipital lobe, and the temporal lobe to the frontal lobe, passing through the anterior third of the external capsule. And we recently also demonstrated a connection provided by the inferior frontooccipital fascicle with the dorsolateral prefrontal cortex that is in fact a critical hub for semantic integration. We also had the chance then to tractography, and this is one of the possible also scientific application of high resolution tractography to categorize the different subcomponents of this bundle, but that's no matter of this paper, of this talk. But what I really want to underline regarding the IFOF is that the mapping, identifying the course of this long bundle over the brain is crucial not only in the hemisphere specialized for language, that most of the time is the left, but also on the right side, because in fact IFOF is crucial also for the non-verbal semantic comprehension. That can be tested with an association, semantic association task like the pan-pyramid tree task. And if you look at, in fact, at the problem of non-verbal comprehension, you will notice that these are strongly right-lateralized in our atlas and follow more or less the same distribution of the semantic verbal functional response on the left side. And in fact, IFOF is a crucial bundle in the end for the integration of the sensory input and the conceptualization and the motor response and the organization of the motor response in reply to that. And in fact, it was a crucial structure also in all the evolution of the brain since the non-human primates to us. What's about the motor networks and in general the right non-dominant hemisphere? So this is the distribution of the pure motor response, and there is nothing special to say about that. This is just to demonstrate to you that the atlas is correctly aligned with the precentral and postcentral gyrus, but also to remember you that motor network is not just a pure motor response, but also the organization of the movement. And in fact, if you look at the distribution of the movement arrest, you will notice that this is bihemispherical and this is mainly located in the deep white matter of the frontal lobe. There is also a sort of dissociation between the arrest of movement and the arrest of language, as you can see in this video, in which we evoked a total motor block of language, but also of movement of the upper limb, and it was in fact due to the deactivation of the connection between the supplementary motor area and the basal ganglia, so of the pure effector component of the system. On the other hand, if you look at the pure speech arrest without motor block, you will notice that these functional responses are distributed more laterally in the white matter connecting the dorsal and ventral posterior cortices of the frontal lobe. You have an example here of this kind of speech articulatory troubles, maybe also stuttering, in which you see the patient was not able to articulate the language, but she was totally able to perform his movement. These fibers in this dorsoventral integration, premotor integration, are the fiber of the frontal aslan tract, are transversal fibers that cover that connect the dorsal cortices of the frontal lobe with the ventral one. So this is just to resume you the different location of this projection effector component and this associative transversal integrative component between the dorsal and the ventral cortices of the frontal lobe. And do remember that the system is bihemispherical and bihemispherical integrated. These are the results of a very interesting paper I had the honor to write with Maxime Descoteaux and Laurent Petit, in which we demonstrated with micro dissection and high resolution tractography that the supplementary motor area of one side is connected heterotopically with the ventral premotor cortex of the other side, and that you have also heterotopic connection between the supplementary motor area from one side and the basal ganglia of the other side. That is in fact the structural background that we can guess, considering the bilateral negative motor response we can evoke on the right or on the left supplementary motor areas and supplementary motor fibers stimulation. So don't forget that the right hemisphere is also crucial for many other higher cognitive functions like spatial perception, that is in fact organized in a frontoparietal network observed by the fibers of the second component of the superior longitudinal fascicle. So the most dorsal part of these longitudinal fibers connecting the parietal lobe with the frontal lobe, and that now we also are attempting and we are trying to start in assessing the ability, the awareness of our patient in emotion recognition, thanks to this great work of Guillaume Herbet that introduced this task that seems able to at least recognize possible impairments in the visual emotional awareness of our patients, in which looks mostly crucial the role of the frontal lobe. So in the end, we use the DAS, the direct electrical stimulation, for improving our results, but also to learn more and more about structural and functional anatomy of the human brain. And we are able also now to use the probabilistic maps coming from this long experience in direct electrical stimulation to adapt, to be merged in your own case, in order to give you the chance to add a tag more to this incredible functional maze that you have to compose for each of your preoperative planning. These are the results of a paper we are recently published in operative neurosurgery, when we describe the pipeline that will allow you soon online to merge our probabilistic functional maps on your individual subject space, in order to try to understand what could be the functional and structural organization of the brain of your own patient. So As you understood, we have a different level of exploration in the human brain. So the structural organization, the functional organization, and then we have to be able to put this information together. And we have no one tool to do that, but we necessarily have to integrate all this information together. To do that, we need a big training for improving our knowledge, of course, but also for creating new methods that can improve more and more our awareness about the systems. On the other hand, we still have to learn so much. You have to imagine, for instance, that we did not yet have a real classification and nomenclature for the human white matter structures. Moreover, don't forget that the system in which we work every day is the most complex object in the non-universe, as Olaf Sporn wrote in a wonderful editorial published in Neuroimage in 2014. But don't forget also that this is also the more dynamic and plastic organ in the known universe. So the knowledge of the system will improve your results, but will also allow you to understand better which are the potential of the organization of your brain, and so to adapt your strategy at individual level to have more and more reliable and also effective results for the life of your patient. So thank you very much for your kind invitation. It was a big honor to be here, and I really hope to visit your country, and you can visit my country as soon as possible. Thank you very much.